Karen. Good afternoon, everyone. I'm Mary Britton from Edinburgh, and on behalf of the BSCR committee, it's my great pleasure to introduce Dr. Anda Bularga as our first presenter today. Anda graduated from the University of Dundee Medical School and is currently a clinical research fellow in the British Heart Foundation Centre for Cardiovascular Science at the University of Edinburgh. Anda is currently undertaking a PhD in cardiovascular data science to evaluate the mechanisms of myocardial injury, cardiovascular disease prevention and detection. Anda's talk today is entitled COVID Heart, Direct and Indirect Effects of COVID-19 on Acute Cardiac Care. So if you're ready, Anda, then please begin your presentation. Thanks.
Okay, thank you very much, Mary. Just to check, my screen is sharing. Yeah, it says that's sharing. Hello, and thank you very much for inviting me to be part of the British Society of Cardiovascular Research Autumn Symposium. It's really a great honour for me to present some of the work that we have been doing at the University of Edinburgh to help understand the cardiovascular implications in patients with COVID-19. But most of all, I'm very much looking forward to hear Professor Davenport's and Professor Guzik's talks and to learn from their experience later on. So as Mary said, my name is Anda and I'm currently a clinical research fellow at the British Heart Foundation Centre for Cardiovascular Science at the University of Edinburgh. And under the supervision of Professor Nicholas Mills and Professor David Newby, my PhD studies involve harnessing the use of data science in cardiovascular disease to evaluate risk stratification and diagnostic pathways for patients with suspected acute coronary syndrome. So I do not have any conflicts to declare in relation to this presentation. However, I wanted to mention that my work and training is supported by the British Heart Foundation, for which I'm very grateful. So just to give you a quick overview about my presentation today. So the aim of this talk is to give you an overview of COVID-19 and mainly concentrate on its direct and indirect effects on the heart and the cardiovascular system that we observed in clinical practice. I will spend a bit of time at the beginning summarizing what we know so far about coronavirus 19 disease, and we'll follow on by discussing the term myocardial injury and its definition. And toward the end, we'll explore in more detail the observed direct effects of COVID-19 and also the indirect effects of the pandemic on provision of cardiac care. So we'll start with a brief overview of the background and the figures up to date and also the epidemiology of COVID-19. As we all know, the timeline started at the end of December 2019 when a cluster of cases of pneumonia were reported from the Wuhan region in China. It was found that the infection was caused by a new strain of coronavirus identified as severe acute respiratory syndrome coronavirus 2, causing a respiratory infection characterized by symptoms of high fever, dry cough, and breathlessness. But really, as time went on, we realized that there was systemic implications of other organs and systems, particularly in critically unwell patients. The infection was spreading rapidly, causing an outbreak in the region of Wuhan, which then evolved with the World Health Organization declaring a state of global health emergency at the end of January. And on the 11th of March, the SARS coronavirus 2 outbreak was declared a global pandemic. The main concerns were the rapid spread of the infection and the relatively high rate of critically unwell patients requiring intensive care associated with poor clinical outcomes. So this slide here gives us just an up-to-date overview of the global situation of as of 2 days ago. So currently we have almost 27 million confirmed cases and over 870,000 of deaths attributed to COVID-19 globally. There has now been a complete global spread, with some regions being affected more than others, and new cases continue to develop. As we all know, the pandemic has brought significant changes to many aspects of our daily lives. The changes the pandemic has brought have been diverse, and this also affected the way we have conducted research. With many research activities on hold due to lockdown restrictions and really due to the pressing need to improve our understanding of this novel condition, many of us had to change directions of our work. In the last few months, there has been an unprecedented scientific production, And this slide was presented at the recent European Society of Cardiology Congress by a team of researchers in Italy who were interested to evaluate the academic work done over the past few months to really assess the impact and quality of this work. Here you can see a PubMed search using the word COVID-19 from January to April 2019 and the significant rise in publications. Quantity, however, does not always equate to quality. And again, the last few months taught us more than ever the importance of critical appraisal and also review in science. Still, I think that there has been an overall grandiose effort in the fight to attenuate the effects of the pandemic. And really, this demonstrates the progress the scientific world has made over the years. So, to cut to chase, there has been a significant number of retrospective observational studies, first coming from Wuhan, China, and then from different regions of the world, which really aimed to improve our understanding of this condition. Here are some figures taken from the International Severe Acute Respiratory and Emerging Infections Consortium Group's initial report on the first 20,133 patients hospitalized with COVID-19 in the UK. The pyramid plot on the left shows us the distribution of age across this population. And we can clearly appreciate how elderly patients are more likely to be affected by a severe form of the disease, requiring hospital admissions, and how the mortality rate, presented in dark purple here, is also higher with increased age. This report found that breathlessness is most common symptom in patients with COVID-19 presenting to hospital, and also that there is a range of other comorbidities in these first 20,000 hospitalized patients in the UK, with chronic cardiac disease leading, diabetes, and also chronic obstructive pulmonary disease. And there is a high overlap between these conditions as well. These findings resonate those from other observational studies, indicating that increased age and cardiovascular comorbidities are common in hospitalized patients with COVID-19, and these are associated with worse clinical outcomes. So now, before we discuss the implications of COVID-19 and cardiovascular system in more detail, I would like to spend a bit of time just going through cardiac biomarkers that we use in clinical practice and the definition and implications of a myocardial injury, which is a relatively newer term that came about in the last decade, really. So there are mainly two cardiac biomarkers used in clinical practice, which have shown association with poor clinical outcomes in COVID-19 patients. Cardiac troponin on the left and brain natriuretic peptide on the right on the slide here. Troponins are regulatory proteins that are integral to the construction of cardiac myocytes. They are released in the bloodstream in response to injury to cardiac muscle cells. And in the last few years, with the improvement in the sensitivity of the assays, we now know that they are not only a mark of injury, but also they tell us about the underlying cardiovascular risk. On the other hand, BNP, or brain natriuretic peptide, is another clinical cardiac biomarker. This is a hormone released by ventricular cardiomyocytes in response to stretch caused by increased blood volume and is a marker of heart failure. So over the past decade, high sensitivity cardiac troponin assays have changed the way we assess patients with suspected acute coronary syndrome. Improvement in assay sensitivity now permit the quantification of very low concentrations of troponin with very high precision, which allows us to use lower diagnostics or risk stratification thresholds. It is really the introduction of high sensitivity cardiac troponins, which are detectable at lower concentration, that has led to the more detailed classification of myocardial injury and infarction. The slide here shows us the fourth universal definition of myocardial infarction reported in 2018, which categorizes myocardial injury in 7 subclassifications. And really, for the purpose of today's talk, we're interested in type 1, type 2, and acute myocardial injury. So just very briefly, type 1 myocardial infarction is a well-known condition characterized by atherosclerotic plaque rupture or erosion event causing decreased blood supply to the myocardium, which in turn leads to ischemia. Type 2 myocardial infarction, on the other hand, is the presence of myocardial ischemia in response to increased oxygen demand or decreased supply to the myocardium. Acute myocardial injury is defined by an acute rise or fall in cardiac troponin on serial testing and can happen in the context of a number of cardiac or systemic conditions. It's just important to mention that in acute myocardial injury, patients don't have evidence of ischemia. So as I was saying, myocardial injury is common, and previous observational studies estimated that more than a third of hospitalized patients can be affected by myocardial injury. As mentioned, it's characterized by a rise and fall in high sensitivity cardiac troponin in the absence of evidence of myocardial ischemia. There is a spectrum of underlying proposed etiologies of myocardial injuries related to the heart and systemic conditions, such as severe hypoxia, hypotension, shock, underlying kidney disease, heart failure, anemia. Now, why is it important to talk about myocardial injury? As I was saying before, it's common in hospitalized patients, even out with cardiology departments, but also a number of observational studies have demonstrated that patients with acute myocardial injury have bad prognosis and long-term clinical outcomes. And at 5 years, there's up to 70% reported mortality in these patients. And this is much higher when compared to patients with heart attacks or type 1 myocardial infarction. So this brings us to the evidence we have today on myocardial injury in patients with COVID-19. This has been commonly reported and described in observational studies over the past few months. Early reports from China clearly identify that patients with COVID-19 and elevated cardiac troponin levels have poor clinical outcomes. There was this study from Wuhan published in The Lancet in March this year that reported on 191 patients with COVID-19, and 175 of these had high sensitivity troponin tested. In those with elevated high sensitivity cardiac troponin, they had much poorer clinical outcomes. And this relationship was more significant than in patients with any other laboratory findings, such as raised Z-dimer or lymphocyte, decreased lymphocyte levels. Later on, more substantial and systemic cohort studies from the US have emerged, demonstrating that 1 in 4 patients have evidence of myocardial injury. Those with a troponin elevation more than 3/3 of the upper reference limit have in-hospital mortality of up to 50%. We also know that these findings are more likely to occur in patients with chronic cardiovascular conditions and in those with severe COVID-19 presentations. Now, there is, however, a problem with this. The vast majority of these findings come from observational studies of selected patients who are admitted to hospital with COVID-19. The prevalence of myocardial injury in these patients varies significantly, as you can see from this diagram, showing that it can vary from 1% to 100%. And this is because these studies are reported from observational studies of selective hospitalized patients. On this slide, I just wanted to show you a forest plot from a meta-analysis that again reported on the association of acute myocardial injury and poor clinical outcomes in COVID-19 patients. So to understand the clinical and management implications of myocardial injury in these patients, we need to have a better understanding of the clinical manifestations and, most important, the underlying mechanisms of this response. Early clinical experience identified a number of well-recognized clinical conditions in patients with COVID-19, from acute myocarditis, which causes widespread myocardial inflammation in response to a viral or bacterial etiology, to stress or Takotsubo cardiomyopathy, which causes a sudden onset typical myocardial dysfunction, where the primary pathophysiological mechanism is thought to be an acute surge of catecholamine response. And there's evidence of a significant arterial and venous thromboembolic disease as well. So there's been a number of potential mechanisms of myocardial injury in COVID-19 that have been proposed, and these are related to different cardiac phenotypes and also have different underlying mechanisms. And we'll hear more about these in the next two talks. But for the next few minutes, I wanted to show us the results of some of our work that we've done in close collaboration with the European Association of Cardiovascular Imaging. We conducted a global survey of echocardiography in COVID-19 patients. This survey covered 1,200 patients from 69 countries in April this year, and we aim to describe the cardiac abnormalities identified in COVID-19. Echocardiography is a very easy and accessible, commonly used method to evaluate cardiac function and also any structural abnormalities of the heart. But however, due to the way the test is performed in close proximity to the patient, there has been concerns about the risk of infection and also the use of PPE. So this global study has made use of readily available data to describe the underlying findings in patients with COVID-19. We also wanted to evaluate the role of cardiac biomarkers, troponin and BNP in guiding investigations in patients with COVID-19. So the slide here demonstrates the global reach of the survey. On the top map, you can see the COVID-19 outbreak areas at the time of the survey in April this year. And the bottom map in blue shows the global distribution of the scans. The majority of scans came mainly from Europe and the US, but these were the highly affected areas at the time of the survey. Out of the 1,200 patients, 55% of these had evidence of an abnormality on their echocardiogram. Patients with an abnormal scans were slightly older and had more moderate or severe symptoms related to their COVID-19 infection. The rate of comorbidities was high, with hypertension, diabetes in 1/3 and 1/5 of patients. So this slide here shows us the findings of the echocardiogram. So as I said before, overall 55% of patients had an abnormal echocardiogram. Left and right ventricular abnormalities were reported in 1/3 of patients. There was evidence of severe cardiac dysfunction in 1/6 of these patients. The rates of new myocardial infarction, myocarditis, and stress cardiomyopathy were less common than in earlier case reports. And here, just a couple of videos just showing a normal heart scan and also a scan showing significant left ventricular dysfunction. So this forest plot here shows the results of the logistic regression model looking at the independent predictors of left and right ventricular abnormality. So left ventricular abnormality in red and right in blue. The clinical presentation and elevated cardiac biomarkers were independent predictors of left ventricular dysfunction, while symptom severity of COVID-19 of right ventricular dysfunction. This is in keeping with clinical reasoning, whereby the right ventricular abnormality are likely related to the severity of the respiratory illness, but also delineates the use of cardiac biomarkers in assessing the need for further evaluation or tests. This plot is quite colorful here, but I'll briefly take you through it. So on the left side, we wanted basically to look at the association between the indication for the heart scan, the findings of the scan, and also the impact or the management resulting following this. Elevated cardiac biomarkers were an indication for a heart scan in 1/5 of the patients, and the scan results led to a change in management in 1/3 of the patients. An example of these are some patients were started on heart failure therapy. Some of these were taken to intensive care unit, or therapy was de-escalated. So I think I have a bit of time, but just very briefly, we're going to discuss about the indirect effects of COVID-19 on provision of cardiac care. You've probably seen in the news, 1 month into the pandemic, while acute care hospitals across the globe were battling the outbreaks, and the way medical care was provided had changed in many ways. Admissions with non-COVID admissions to hospital had decreased considerably. And there was a realization that patients were not presenting to hospital amongst all this crisis, possibly due to the fear of catching the infection, or because they didn't know what the plan would be and what to do. So international forces gathered to evaluate the problem, and the European Society of Cardiologists conducted another survey across 141 countries, with respondents indicated that they estimated that 50% decrease in heart attack presentation, and this finding was consistent across the globe. The slide here shows us some plots from a recent publication from here in England across 147 acute care hospitals, which aimed to evaluate the admissions with heart attacks in the UK. And really, they compared the admissions in 2019 with those in 2020. There was a significant reduction, as you can see, in admission during March and April, during lockdown time. And the concern really is that as time passes, we are going to see the consequences of patients not presenting to hospital. And there's going to be high rates of heart failure and other hospital admissions in the coming years. Now, we observed a similar decrease in hospital admissions in NHS Lothian, and our research team wanted to find out what are the perceived barriers from patients' perspective. So in a study conducted by Dr. Amy Ferry, one of our research nurses, the team organized semi-structured telephone interviews with patients that presented to hospital with chest pain during the pandemic and patients with long-term known cardiovascular disease. The findings showed varied reasons to avoiding presentations to hospital. Majority of patients reported that their decisions making was affected by COVID-19. However, for those who came into hospital because of a cardiac problem, the experience was positive. And there is a clear role for ongoing public education and communication. So in summary, I hope that I managed to give you an overview of the clinical cardiovascular implications of COVID-19 that we have observed so far and the lessons we've learned. Myocardial injury is common and is associated with poor clinical outcomes in these patients. Elevated cardiac troponin concentrations are also common in hospitalized patients with COVID-19 and are more likely to be attributable to non-ischemic causes of myocardial injury, with its significant left and right ventricular abnormalities. Understanding the underlying mechanisms of myocardial injury is an important aspect which can lead to therapeutic interventions. So ongoing research is required to improve our understanding of these mechanisms. I would like to thank my supervisors, Professor Nicholas Mills and Professor Newby, for their ongoing guidance and support, and to all my colleagues and mentors who provide valuable learning. And thank you very much again for inviting me, and I welcome questions.
Thank you very much, Anja. That was a really, really great presentation. Can I just ask for people who, if you have any questions, just to type them into the Q&A box and I'll try to get through those. I'll keep an eye on those just now. And I'll start off the questions just now, Anja, if that's okay. Yeah. So you mentioned this in your sort of closing remarks, but I was wondering if what is known about the potential mechanisms that may underlie the elevation of troponin or other biomarkers in relation to COVID. For example, is there anything known about the response to the cytokine storm, or is there any evidence that troponin is acting through ACE2 receptors?
Yeah, can you hear me? Sorry, I was going to go to my kind of mechanism slide. So these are all proposed mechanisms to know how kind of why myocardial injury happens. And we do suspect that all these mechanisms that you mentioned, also the increased inflammatory response, prothrombotic response, procoagulant responses, they all play a role in endothelial dysfunction, and also like that leading to myocyte injury and dysfunction.
So in general, is there any evidence that, well obviously COVID-19 is now quite often cited as a microvascular disease or disease of endothelial function. Is there any evidence in general that troponin would influence endothelial cell function?
Not to my knowledge, not that I know. I think this has given us this opportunity to investigate these further, and I think you know, can't compare to anything before that is leading us to really understand these mechanisms leading to myocardial injury out with kind of primary ischemic causes and components.
Okay, so I have a question here for you from Stéphane Bourgeois, who asks, there's been a recent preprint reporting COVID-19 which appeared to induce some kind of cleavage of the sarcomeres in cardiomyocytes. Would that kind of injury be reflected in troponin levels?
Yes, because I suspect so, because troponin is a protein present in the sarcomere. So I suspect that would be kind of a direct implication. I need to go back and read a paper as well. But because troponin is a regulatory protein of the sarcomere apparatus and the contracting myocyte apparatus, I suspect that would have an implication.
Okay, that's great. There's another question in the chat box which says, is troponin regulated by cytokines? Which I think you've already probably largely covered with your slide that's still up at the moment, as one of the potential mechanisms, the cytokine storm.
Yeah, so yes, this was one of the potential mechanisms that's suspected to be underlying some of these pathologies, such as coronary microvascular ischemia, also stress cardiomyopathy, leading to other complications such as the tachyarrhythmias that we see as well.
Mm-hmm. There's another question from an attendee who says, thank you very much for a very insightful presentation. And is there any evidence for a direct infection of the heart by SARS-CoV-2? If so, is the virus present in the circulation?
So I'm aware there has been a lot of autopsy studies as well, and I know, Mary, you've been involved in them as well. And there's been some conflicting reports. Initially, there was some cases where there was found some direct involvement of the viral cells and myocardium, but most recent papers that I read, it was more related to the indirect effects of this, right, rather than the primary involvement. But you can correct me, Mary, if I'm not right.
No, that's the same as what I know at the moment as well.
Yeah, so I think it's just all the learning process, but you know, as I was saying, everything's changed. The way we're doing the work we're doing has changed, but I do think out with COVID and out with what's happening at the moment, we are going to learn so much about all these pathological mechanisms.
Absolutely. So there's a further question from Cherry Wainwright, who says, is there any evidence for a relationship between activation of platelets and myocardial injury?
Yes, very good, very good question, because that's activation of the platelet cascade. That's a primary mechanism in what happens in type 1 myocardial infarction, and that's kind of plaque rupture, plaque erosion event, and that would respond for myocardial injury as well. So, you know, myocardial injury is like an umbrella term, which encompasses so many pathologies. Most commonly one of the most known ones being type 1 myocardial infarction. But because these high sensitivity troponins have led us to recognize all these other implications, we recognize the other mechanisms as well. But yes, platelet aggregation, platelet cascade does have major implications in myocardial injury leading to ischemia, which is the definition of myocardial infarction or type 1 MI.
Okay, so there's another couple of questions here. The first is from Lalit Dubé at QMUL, who says, nice talk. And to add on to previous questions, which cardiac cell types are the direct targets here?
They could be cardiac myocytes that are injured, and the necrosis or apoptosis of these cells leads to the release of troponin in the bloodstream, and the way we can detect it.
Okay, and a question from Sanjay Sinha. who says, you said myocardial injury is common, although clearly the incidence varies in different studies. So how does this compare to other severe viral infections such as influenza or septicemia?
That's a very, very good question. And I really was hoping I can present you some local data that we're working on, but it's not ready yet. And that's the main issue that we are facing, I think, because the degree, as I was saying, of the incidence of myocardial injury is so variable. You don't know how, it's a serious problem, but what's the degree of this problem? We still don't know. So we're trying to find that out by actually in Leuven we have been, since April, we have been testing all consecutive patients coming into hospital who have a COVID-19 test for any reason, just to see what the prevalence would be in unselected patients. Sorry, can you just repeat the question again? I think I'm diversing. So.
Sure. Sanjay was asking how the incidence of myocardial injury compares to that in
Yes,
other severe viral
sorry,
infections.
yes. So we know that other severe viral infection, pneumonias, are also associated with myocardial injury. I think so far the incidence of myocardial injury in COVID-19 is probably around 15–20%. I was saying we need studies of unselected patients. And from literature reviews that I've done, it's closer. It's close to that of other infections. The issue is we haven't studied other infections in so much detail as we are doing now. So probably we'll find out more.
Okay. Can I just ask another question? With the patients with myocardial injury in your study, was this always secondary to acute lung injury? And also, did you see any patients in your studies that presented with myocardial injury as a result of the COVID-19 infection that had previously had no established or underlying coronary artery disease?
Yes, so in this survey study, the patients had, there was a range of patients that had echocardiograms for many reasons. Some of them had severe symptoms of their respiratory infection, and these ones who had severe symptoms were more likely to have adverse findings on their echocardiogram. We also did, when we reported our study, we also did the sensitivity analysis, whereby from the full study population, we excluded patients with previous cardiovascular disease, and that was ischemic heart disease, heart failure, or valve disease. And we wanted to see whether in this population of patients who don't have anything recorded in the past, the associations are the same. And we did find that there was a similar proportion of patients, around 50% of them had an abnormal scan, which leads us to think that these findings were more in relation to their COVID illness rather than any pre-existing problems.
Okay, that's fascinating. And that's where the mechanistic insight will be very useful.
Yes. So almost like we're going a bit backward just to find, what that exact mechanism is, the pathophysiology.
So there doesn't seem to be any final questions from the participants, but I just wanted to ask you one question about the last part of your talk, where you showed the decrease in the hospital admissions all over the world of patients with acute coronary symptom, which is just really so strange and unusual. And what kind of time frame, obviously we're awaiting some kind of impact of that, whatever it might be, and what kind of time frame do you think we'll start to see the sort of the negative outcomes of those patients who didn't go to hospital?
Yes, it really depends on if someone has, for example, a late presentation heart attack. It really depends on the size of the injury and how much heart muscle was affected. And development of heart failure can be, in some cases, acute within days, but it can take up to years. So I think we are going to see the consequences of these over the next few months and also years, because in view of this acute scenario, people were just not coming to hospital. And as you said, the figures are very surprising.
Okay. So there's two questions, which I think will be the final questions before we hand over, that have just come in. So the first is from Daniel Brayson, who asks whether there's any evidence that asymptomatic COVID patients can develop cardiac disease.
Excellent question. I don't know the precise answer to this, because the issue is that these patients are usually those who are at home, who don't come in, don't come into hospital, and they are the ones that are not being investigated. Hence, the limitations of these selected hospitalized patient studies. However, in some of these studies, you'd see, for example, our echo survey did include patients with very mild symptoms, and they still had some abnormal findings on the echocardiogram, although the proportion was much smaller.
Okay, so the final question is from Daniel Stuckey, who says, you showed some very interesting ultrasound data, which is great as it can be acquired across the globe. But would you think cardiac MRI or CT could give more accurate data, which would be more likely to inform patient care?
Of course, and there's actually ongoing studies looking at cardiac MRI findings in patients with COVID-19 and evaluating their coronary status as well, to see whether the underlying, even unknown coronary disease has an implication in these findings. Because, as you probably know, that the limitation of an echo is, we can't define or diagnose a myocardial infarction or even myocarditis by echo alone. So I suspect in some of these cases, this was done more as a diagnosis of exclusion, taking account the whole picture, and hence the very small numbers of these conditions that we saw. But investigations such as MRI and CT will be adding more evidence, and there are studies that have been conducted and concluded. There's ongoing studies as well. And also interestingly to mention that following this is all reporting on the acute phase of the condition, but we need to know the reversibility of it as well. So I think follow-up studies will be very important as well, because we know, for example, that in cases of other viral infections or flu or pneumonias, most of them, the reversibility of decreased right cardiac dysfunction is reversible. We need to know if this is the same in COVID-19, because it has major implications for the patient, but also for healthcare systems.
Okay, that's fantastic. Thank you very much again, Anda, for a really fascinating talk, and
thank you,
and for your time.
Thank you for having me.
And now I'll pass